Hi friends, this video is on neurophysiology. We are going to discuss a disease related to the CNS, and that's the multiple sclerosis. Now this is a demyelinating disease of the neuron or the nervous system, and due to the demyelination what happens is there are manifestations of conduction block through the nerves. Not only that, what happens is this is not a consistent feature. What happens is there are exacerbations of the manifestations in certain situations. The conduction block and its manifestations become worse under certain situations. For instance, hot bath and the symptoms worsen. So, to understand all these symptoms and to understand the management, we will need to first understand the transmission of impulse through the nerve, through a myelinated axon, through an unmyelinated axon, and then what happens when there is demyelination of a myelinated axon or nerve fiber. Look, the point is simple. We have myelinated nerve fibers and we have unmyelinated nerve fibers right from the beginning. Now this myelinated nerve fiber is demyelinated. That means it should now become an unmyelinated nerve fiber. And just like any other unmyelinated nerve fiber which does carry the impulse, even this, the myelinated axon now has got demyelinated, so it should be able to carry the impulse as well. But that does not happen. The myelinated nerve fiber, when its myelin sheath is gone, it is not able to carry the impulses. The impulse propagation stops and the manifestations such as tingling, numbness, electric shock like sensation, all these appear. So, to understand why it happens like this, let us first understand the propagation of impulses through the myelinated nerve fibers and the unmyelinated nerve fibers. I hope you understand what I am trying to say, or what I am trying to establish here is that we already have unmyelinated nerve fibers right from our birth and they are carrying the impulses. So when the myelinated nerve fiber becomes demyelinated, means now the myelin is gone, why it doesn't behave like an unmyelinated nerve fiber and carry the impulses? That's the whole point of this discussion, and then we will see what happens at a molecular level and what are the management strategies related to it. Right. So, as I mentioned just now, we have the myelinated axon, the myelinated nerve fiber, and we have the non-myelinated or unmyelinated nerve fiber. Let's first see what happens in the case of an unmyelinated nerve fiber, how the impulses travel through an unmyelinated nerve fiber. First point, in the case of unmyelinated nerve fibers, the C fiber type, you know there are 6 types of nerve fibers, A alpha, A beta, A gamma, A delta, B and C. A and B fibers are myelinated and C fiber is unmyelinated. How the impulse is conducted through this fiber type? The first point that one must understand is that the voltage gated sodium channels, which are responsible for depolarization and excitation of the membrane, these voltage gated sodium channels are located at very close distances in the case of the unmyelinated nerve fibers. Whereas in the case of myelinated axon, myelinated nerve fiber, you know the myelin sheath is broken at regular distances and axonal membrane is exposed. These are called as nodes of Ranvier. The point is, the sodium channels are present concentrated only at the nodes of Ranvier, and there are no sodium channels beneath the myelin sheath. So you can see here diagrammatically it has been represented like this. The sodium channels, particularly in this case, they are of a specific type which is called as NAV 1.6. NAV 1.6 is sodium voltage, so voltage gated sodium channels, and these channels are responsible for repetitive firing of action potentials through the nerves. So these are concentrated at the nodes of Ranvier. Let's compare the two action potentials, or rather propagation of the action potentials, how the impulse propagates. The key point in all this propagation is that sodium and the positive charges, they will come in from one point. The point will excite, but those positive charges have to go to the next point where the sodium channels are located, and they should take that point to threshold. I mean, the positive charges that are coming in, they should reach the next location of sodium channels in substantial amounts, so that that next point, whether it is the immediate next point in the case of unmyelinated nerve fiber, or it is the next node of Ranvier in the case of myelinated nerve fiber, the positive charges coming in from one point, they should reach that next point in the substantial amounts, so that the next point automatically reaches threshold, and that next point excites, generates the action potential, and positive charges would come in from that point, and they will travel to the next third point where the sodium channel is located. So that's the key point that we are looking at when we discuss the propagation or lack of propagation in the nerve fibers. Right. Just to give you the example, I have given this example in one of my previous videos as well. Consider this unmyelinated axon. How the impulse propagation happens. Compare this with the red firecrackers. I am sure most of you have seen that line of red firecrackers. What happens is, we just put fire to the first cracker, it reaches threshold and it bursts. While it is bursting, it passes the flame to the next cracker. So next cracker automatically reaches threshold and bursts. And while bursting, it passes the flame to the third cracker. So third cracker automatically reaches threshold and it bursts, and it goes on happening, and further the firecrackers go on bursting. So once first cracker reaches threshold, then we don't have to do anything. It will go on bursting all by itself. Same thing. Now imagine in the case of action potential propagation through the unmyelinated nerve fiber. Stimulus applied to the first point reaching threshold and generating the action potential. Sodium, the positive charges are coming in, and this point has, first point has excited. Those positive charges, they reach the next adjacent point where the sodium channels are located, and the next point reaches threshold automatically by those positive charges which have come in. So now sodium channels open there, and that point bursts into action potential, the depolarization, and sodium and positive charges have come in. Those positive charges will go to the next adjacent point where the sodium channels are located, and this will go on happening. So it's a self-regenerative process. Now the point is, what is the advantage, the benefit offered by the myelin sheath? Look, there is a concept of membrane capacitance, that the axonal membrane has the capacitance of course, and it is inverse of the resistance. It's inversely related to the membrane resistance. So, the charges that have come in, the positive charges which have come in, they leak out of the membrane due to this membrane capacitance. And therefore, you can see in the case of unmyelinated nerve fiber, the sodium channels are located at very close by distances, because what is the condition? The condition is whatever positive charges enter from one point, they should reach an adequate amount, so that, and adequate amounts to what point? To that next location where the sodium channels are located. That next point should automatically reach threshold by the positive charges that have entered from the previous point and reaching that second point. So, unmyelinated nerve fiber has been given this because of the so-called membrane capacitance, that the positive charges, as they start traveling, they leak out. They are going to leak out of the membrane due to the membrane capacitance, and therefore the strength of that current will become weak and weak as it travels. So, unmyelinated nerve fiber, the charges just have to go to the adjacent point. Now coming to the myelinated nerve fiber. The myelinated axon has sodium channels concentrated only at the nodes of Ranvier. Why that is affordable is because the myelin sheath decreases the membrane capacitance and increases, it means it increases the membrane resistance. Since myelin, it acts like an insulator, it increases the resistance of the membrane, so that the sodium ions and the positive charges that enter from one node of Ranvier, they can travel in substantial amounts and reach the next node of Ranvier, so that, that positive charges, those positive charges, the current strength should be good enough to cause next node of Ranvier to reach threshold. This next node of Ranvier should reach threshold by the charges that are coming in from the previous node of Ranvier. That is the whole fundamental of this discussion. Well, myelin increases the resistance, decreases the capacitance, and therefore what you can see is, in the case of myelinated axon, the action potentials are generated at the nodes of Ranvier, means at long distances, compared with the unmyelinated axon, where every next point has to reach threshold, every next point has to generate the action potential. So naturally this will be slower, and compared to that, the myelinated axon will be faster, because only a few points are going to depolarize, only a few points, the nodes of Ranvier are going to excite. So it's obviously going to be faster. Now coming to the one more term, of course, which I wanted to introduce at this point, is the electrotonic conduction. Electrotonic conduction. It is a direct and passive spread of charges from the point of entry. The charges enter from one point, and then there will be a flow of those charges passively, a direct and passive transfer of charges or flow of charges. So they are carrying that certain current strength, and that carrying of current strength passively over a certain distance is called as electrotonic conduction. So it could happen anywhere in the body. Wherever you find the localized current flowing, it can be called as electrotonic transmission or electrotonic conduction. So, we can say that myelinated nerve fiber, its impulse propagation is called as saltatory conduction. Saltare means leap or jump, because in comparison with the unmyelinated nerve fiber, the myelinated axon generates action potential only at far distances, only at the nodes of Ranvier, and therefore it appears to be jumping. Let me just clarify this point. Very often people think something is actually jumping, some physical body is actually jumping. That's not the case. Actually, that's not the case, because the nodes of Ranvier are developing action potential. Therefore, it appears that the action potential has jumped a long distance. But in reality, it's the transfer of charges electrotonically or passively from within the axon itself. Right. So, saltatory conduction can be said to be a combination of action potentials at the nodes of Ranvier and node to node electrotonic conduction. So, that's the impulse propagation through the two types of nerve fibers. The point is, when myelinated nerve fiber loses its myelin sheath, it's called demyelination, and multiple sclerosis is a demyelinating disease. So, if the myelin is lost, what is the result? What is going to happen? And as I mentioned at the start, now it is an unmyelinated nerve fiber, and unmyelinated nerve fibers have the capacity to conduct the action potentials. Why is it then that this myelinated axon now has become unmyelinated but is not able to carry the impulse in a normal way? We will look at that, and of course we will also see the manifestations of the multiple sclerosis and how it should be treated. So, here are a few points. First, electrotonic conduction, it's a passive spread of charges from the site of stimulus. So, charges enter from one point and they just passively spread over a certain distance. Now, this electrotonic potential decays exponentially with distance. Yes, as we have mentioned that the axonal membrane has the capacitance, and because of that there will be leakage of charges. As the current flows, there will be leakage of charges across that membrane. Therefore, electrotonically conducted signal dies away over a certain distance, let's say a few millimeters. Remember, electrotonic conduction can carry the signal, can carry the current maximally up to 10 millimeter length of the axon. By 10 millimeter length, it will be completely extinguished. It will completely disappear by 10 millimeter length. And why is that? Because of the membrane capacitance. In that context, we have a definition, the length constant, or it's also called space constant. The distance over which the potential change decreases to 1 upon E, or 37% of its maximal value. I mean, it was stimulated at one point and the charges have entered completely through that first point. Then, as the charges travel, the current strength will decrease to 37% of its maximal value. That much distance is called as length constant. So, that's the definition of the length constant, the distance over which the potential change decreases to 37% of its maximal value. and or 1 upon E. E is of course the base of natural logarithms and is equal to 2.7182. For mammalian axons, the length constant is about 1 to 3 millimeters. So as I mentioned, over 3 millimeters length of the axon, the current strength of the this electrotonic conduction will decrease to 37% of its maximal value, and that's how it will decay exponentially, and that's because of the leakage of charges across the membrane, axonal membrane, right? Therefore, by 10 millimeter lengths, it will become, those charges will be completely dissipated. Charges have leaked out because of capacitance, and that's it. I mean, 10 millimeter length is the maximum that can be carried by the electrotonic potential. We have also seen the importance of myelin. So this is just a quick revision. Myelin increases the membrane resistance, and that is decreases the capacitance. Hence, it prevents the leakage of charges. You know, resistance of the membrane means it will prevent the leakage of charges. Capacitance means it allows the leakage of charges. So, thereby increasing the length constant. Yes, myelin sheath increases the length constant. Yeah, I mean, we have said that already, that due to the myelin, the charges will travel over a long distance with less leakage. So, the length constant will increase. Now, considering that the average internodal distance is about 1 to 3 millimeters is the average internodal distance, and the length constant is also 1 to 3 millimeters. So, generally it is said that if the demyelination involves about 3 nodes of Ranvier or 10 millimeter length of the axon is involved in demyelination, then the symptoms become severe, because electrotonically, if the impulse has to be carried, it can be carried only over 10 millimeter length. That's the max. So, we will come to that in a moment. Let's now discuss the multiple sclerosis with all this background in mind. Multiple sclerosis is the most common demyelinating disease of the CNS. Now we are going to discuss why is it that the myelinated axon has got demyelinated, so it is now an unmyelinated axon, yet it's not able to carry the impulse, or impulse conduction block happens. Okay, so autoimmune disease, it's an autoimmune type of disease directed against the myelin or the oligodendrocytes which form the myelin in the CNS neurons. Right. What are the signs and symptoms of this disease? It decreased visual acuity due to the optic neuritis. So we will see there is a conduction block and the inflammation of the white matter in the spinal cord. So there will be some manifestations in the cranial nerves, or in the case of spinal nerves, peripheral nerves as well. So diplopia, double vision due to the degeneration of neurons that innervate the extraocular muscles. And there is a sign, the Hermitage sign, electrical sensation that shoots down the back and into the legs when the neck is flexed. So, this is a sign which is seen in multiple sclerosis. It's defined clinically. Multiple sclerosis is defined as a disease that involves demyelination of CNS. Now listen to this part. Demyelination of the CNS neurons with episodes separated in both time and space. There will be episodes of conduction block. The neurons have been demyelinated in the CNS. So, impulse conduction will become difficult. So, there will be manifestations of that. But when will you actually diagnose it as multiple sclerosis? 2 episodes separated in both time and space. So, there should be 2 separate episodes. and they should involve two separate regions in the CNS to be called and diagnosed as the multiple sclerosis. And one often finds the exacerbation of symptoms when there is active inflammation and that of the white matter tract in the CNS. You know, sensations are carried from the periphery when they enter the spinal cord. There are ascending tracts, and that white matter, there can be inflammation of that will result in the exacerbation of symptoms. In fact, in this particular disease, you will find the cycle of the exacerbation, then remission, and then relapse of symptoms again. So, talking about the molecular changes, what happens actually at a molecular level? Replacement of the NaV 1.6 channels. We saw these channels just now, that these are the channels, voltage gated sodium channels. They are responsible for depolarization. Now, these get replaced in many cases by NaV 1.2 channels in those demyelinated axons. So, basically NaV 1.6 is the primary channel which is responsible for depolarization of the nodes of Ranvier, and this channel is able to sustain repetitive excitation, that regenerative firing, repetitive excitation of the neurons. That's possible because of this channel. NaV 1.2 is found at the distal end of the axon hillock. But just remember, just for an additional information, in the early stages of myelination, NaV 1.2 is the channel that's present, and it does get replaced with NaV 1.6. When myelination is completed, it's the NaV 1.6 channel which is going to be there permanently until demyelination. Of course, when demyelination happens, again NaV 1.2 comes back. So that's what happens at the molecular level. Now, conduction in the demyelinated fibers, remember I have mentioned this just some time ago, that the conduction in the demyelinated fibers is just about adequate. Under normal circumstances, conduction will be barely possible, but it will be blocked when certain situations arise. For example, heat, hot bath, increased temperature of the skin, increased temperature of the body, or stressful situations faced by that individual. So, all these circumstances will cause appearance of manifestations of conduction block. In fact, it's been described as the Uthoff's symptom, heat sensitivity. When the body temperature of this patient is elevated, conduction is compromised and symptoms of neurological deficit will appear. For example, a hot bath taken and there is a transient visual blurring because of the optic neuritis, the second cranial nerve involved, or third, fourth, sixth cranial nerves involved, and therefore diplopia, double vision, that's possible. Right. Low temperatures, they will improve the symptoms. Now, why is that? Look, basically, let's just have this diagram. Normal axon, normal nerve fiber, action potential develops at the node of Ranvier, and sodium is carrying the positive charges. They travel a long distance and reach the next node of Ranvier in substantial amount. That current strength is good enough to generate, to cause next node of Ranvier to reach the threshold and generate the action potential at the next node of Ranvier. Then the sodium will come in from that node and will travel to the next node. What happens in multiple sclerosis? Now, this segment has been shown to be demyelinated. Myelin is gone. What do you expect? What will happen is that the charges that come in from one node of Ranvier, now those charges will leak out of the membrane, because now the capacitance has increased, resistance is gone or decreased because the myelin is gone. And therefore, you can see those charges, when they reach the next node of Ranvier, or where there was previous next node of Ranvier, the current strength has diminished greatly, and therefore that next point, the next node of Ranvier, will not be able to reach the threshold, and therefore it will fail to excite and the impulse will stop completely. So that's what happens in the case of multiple sclerosis. However, we can see in the same diagram that we have mentioned this, that the sodium channels, the NAV 1.6, is located only at the nodes and no sodium channels beneath the myelin sheath. Beneath the myelin sheath, there are no sodium channels. Well, over a period of time, consider a case of multiple sclerosis and the manifestations of conduction block have appeared. But over a period of time, what happens is the sodium channels will get redistributed. There is redistribution of sodium channels. Those were concentrated at those nodes of Ranvier, means at long distances. Now, those sodium channels will get redistributed and they will be close to each other, like the unmyelinated nerve fiber. Remember, we had drawn the diagram of unmyelinated axon, where sodium channels were located at very close by distances, so that the charges do not have to travel a long distance, just they have to excite the next point. Just next point has to reach the threshold. Similar thing now happens here. Sodium channels will get redistributed over a period of time, and then the manifestations will cease, means there will be remission of symptoms. Symptoms will stop because now there are sodium channels at regular distances, but the neuron is demyelinated. Okay, right. So that's what happens in the multiple sclerosis. Initially, demyelination has happened, impulse conduction block will happen, plus there will be inflammation of the white matter in the spinal cord, those ascending tracts, have the nerve fibers having myelin sheath. With the inflammation, there will be exacerbation of symptoms, and then with this sodium channel redistribution, there will be remission, the symptoms will disappear. So that's, of course, one more point just of academic interest maybe, that in the myelinated axons, action potential travels as a saltatory conduction and therefore quite a faster velocity, 70 meters per second. But in the case of unmyelinated axon, I beg your pardon, in the case of unmyelinated axon, the conduction velocity is slower, 1 meter per second. So now the same axon, same nerve fiber which used to carry the impulse at 70 meters per second, now it has got demyelinated and eventually it has become like an unmyelinated nerve fiber. It will conduct the impulse at 1 meter per second. So these are the things that are seen in multiple sclerosis. Now, conduction failure, let me just add a few more points related to the conduction failure that will add conceptually to our understanding of pathophysiology. It happens because of two reasons: leakage of currents as they travel through the demyelinated segment. We saw that already, the membrane has capacitance, so leakage of charges, and therefore sodium ions fail to reach the next node of Ranvier in substantial amounts. Hence, action potential cannot be generated at the next node. Second point which we should not miss, because treatment strategy is related to this second point. So listen to that. With demyelination, the potassium channels which are normally buried underneath the myelin sheath, they will get exposed. Look, we have said that there are no sodium channels beneath the myelin sheath, but there are potassium channels. They can bring about the repolarization of the segment. Now, potassium channels are generally buried beneath this myelin sheath, underneath the myelin sheath. And now what is going to happen with demyelination? As the myelin is gone, these potassium channels, they will be exposed, and exit of potassium through these channels is going to hasten the repolarization, and in fact hyperpolarization of the membrane is also likely to occur. So this will make the excitation that much more difficult for this neuron. Transmission of impulse will be that much more difficult because potassium channel, which was beneath this myelin sheath, now there is demyelination. So potassium channel has got exposed. There will be there is outwardly rectifying potassium current. Potassium leaving through these potassium channels. So not only that the current brought in by the sodium ions that's leaking out of the membrane, but potassium also is actively taking out the positive charge. Not actively means potassium is taking the charges along with it, and therefore lot of leakage of positive charges. Therefore naturally there will be hyperpolarization. Potassium leakage results in hyperpolarization, membrane fails to excite. And as I mentioned, the conduction block is temporary. Eventually the sodium channels will be redistributed, as we saw in the previous diagram, that sodium channels will now redistribute and they will be like an unmyelinated nerve fiber. So propagation can start again like the unmyelinated nerve fiber. It will be slower. There will be a variable conduction block with raised body temperature or metabolic alterations, and this explains the clinical fluctuations which is typical of MS. Means it's not predictable or it does not occur at a known frequency. It's quite a fluctuating type of onset of symptoms or appearance and severity of the symptoms. It will vary from hour to hour. That's one dreadful thing about this disease, that it keeps on changing. Due to these circumstances, there will be appearance of manifestations and it keeps on changing. It's associated with fever, exercise. So that is the multiple sclerosis and its manifestations, why they appear. Let's now finally discuss the diagnostic criteria and the treatment strategy. Basically, diagnostic tests are MRI, evoked potentials. Yes, evoked potentials. This is related to the physiology, so I thought I'll include it. Repetitive stimulation of some selected peripheral nerves. Let's say stimulation of the sensory nerve coming from the foot is stimulated repetitively, and it will evoke specific electrical potentials in the CNS. Those potentials can be recorded from the CNS, because the impulses which start from that peripheral nerve in the foot, they will reach the cortex and they can be recorded. Those potentials can be recorded. Basically, they are called as evoked potentials. We have repetitively stimulated that nerve to evoke the potentials in the somatosensory cortex, and therefore these are called as evoked potentials. Now, these tests will be most useful, either MRI or evoked potentials will be most useful when the pathways studied are not clinically involved. I mean, imagine in most cases, just by clinical examination, one can diagnose which nerves or nerve fiber tracts have been involved in the demyelination. So, why would you perform the additional tests like MRI or evoked potentials? These tests will be most useful when the pathways studied are not clinically involved. You could not clinically diagnose which nerve or which nerve fiber tract in the CNS is involved. We could not diagnose that clinically, so these will be helpful. Example, I'll just explain what I'm trying to say here. In a patient with a spinal cord syndrome with sensory deficits in the legs, let's say it's a spinal cord syndrome and sensory deficit is in the legs, patient has come to the doctor with that sensory deficit in the leg, the paresthesia, tingling, numbness or any such manifestation. An abnormal somatosensory evoked potential after posterior tibial nerve stimulation. I mean, in this case, in this patient is already complaining about some sensory deficit in the leg, and if you perform the evoked potential test on the leg, let's say stimulation of the posterior tibial nerve, that will not provide any new information because already it's clinically evident. But in this patient, suppose if you perform MRI or evoked potential and an abnormal visual evoked potential was found related to the optic nerve, then yes, we can diagnose. I mean, it will be helpful in the diagnosis, because remember what we have said in the clinical definition of multiple sclerosis. There should be two episodes separated with time and space. So, some nerve in the lower limb is involved and the optic nerve involved. Two nerves involvement, second nerve confirmed by your investigation. First nerve involvement in the limb was already evident by the patient's history giving. A patient has come up with that nerve, and you have now recorded the optic nerve evoked potentials, and you got that also as demyelinated nerve. Then yes, the diagnosis will be obvious. Two nerves involved, separated by the space, and episodes separated by time. So it's a definitive MS in that case. There is also scoring system for the MS. The Kurzges's Expanded Disability Status Score, EDSS, it's so called. It's called Kurzges's EDSS. The score has a scale from 0.0 to 10.0. 0.0 is the normal neurological examination, whereas 10.0 is death due to MS. Yes, demyelination and conduction failure can lead to the respiratory paralysis or and any such severe manifestations that can result in death as well. So, that's the scoring system. Well, now let's just look at the treatment strategy finally. The augmented currents of a broader spike will make it more likely that the threshold for the continued conduction will be reached. Yes, the broader spike. Look, normally what happens is the spike is let's say at one point of the nerve. Let's say this is a point which is stimulated and it excites. Graphically, we show the spike like this, depolarization, and then depolarization has ended quickly and there is repolarization. Now instead, if there is some mechanism by which we can make this spike little broader and repolarization is delayed, then it helps in the propagation. For example, depolarization like this and repolarization, a broad spike. It means repolarization has got delayed. That's number one. Potassium exit has got delayed. Plus, broader spike means the sodium entry and the current that is carried by the sodium ions, it remains for a longer duration and it can carry the current for a slightly greater distance. You can see this was a normal spike from a normal nerve, and this is a broader spike generated. When we give some drug treatment, a broader spike can be generated. I'll come to that in a minute. But a broad spike generation is helpful if we can do it by the drug treatment. Right. So, with that broad spike, sodium carries the current at longer distance, and the threshold for that continued conduction will be reached. What was the prerequisite? We have at the starting point itself, I have mentioned this. What is the prerequisite for impulse propagation to happen on its own? The next point where there is sodium channels located, that next point should receive adequate current strength. From the previous point, sodium has come in. So, the next point should receive adequate number of positive charges so that it reaches threshold by itself, by those positive charges which have come in. So, that is possible by these broad spikes. Certain drugs can prolong the duration of action potential. That's what is a broad spike, broad action potential, duration increase, and facilitate the conduction through the demyelinated axons. What is the mechanism? Yes, that's the most important part. Demyelination exposes the voltage gated potassium channels. Yes, we saw that just now. And activation of the outwardly rectifying potassium channels, potassium currents, means potassium going out. This will further impair the spike production. So, what we are saying here is that if the potassium is allowed to go out rapidly and repolarization happening very rapidly, what is going to happen? Repolarization quickly happening, narrow spike happening, and therefore conduction block will become very apparent, very evident. But what we can achieve, what we can actually implement as a strategy, as these potassium channels can be acted upon because now they are accessible due to demyelination by the class of drugs which are called as potassium channel blockers, called aminopyridines. We don't want that potassium to go out and carry positive charges out of the axon. We don't want the current strength to diminish. So, block the potassium channels, don't allow, and we can target them because now the myelin is gone, the potassium channels have got exposed. So, blocking the potassium channels can broaden the spike, can prolong the spike, as I have mentioned just now, and propagation will be facilitated, it will improve. So, that's the treatment strategy basically. Potassium channel blockers, how would they be helpful? Right. So, that was about the multiple sclerosis, the most common demyelinating disease of the central nervous system. The most common demyelinating disease of the peripheral nervous system is the GBS, the so-called GBS is Guillain-Barré syndrome or Landry-Guillain-Barré syndrome. That too is caused by autoimmunity to the myelin sheath formed by the Schwann cell. The peripheral nerves are myelinated by Schwann cells. So, that's in the peripheral nervous system. These patients recover fully because the peripheral nervous system has the ability to remyelinate itself. You know, the peripheral nerves, they can regenerate and repair themselves, and therefore, well, compared to that, the axons in the CNS do not regenerate and repair. That will be the matter for some other video. We will discuss it later, or the oligodendrocyte versus Schwann cells and myelination and so on. But this particular video, my focus was completely on this, that the multiple sclerosis is the disease in which there is demyelination. What are the problems of demyelination and how we can treat it? Basically, remember, the potassium channel blockers will block that potassium exit, broaden the spikes. So, a current strength can remain over a certain distance and conduction block can be treated like that. So that was the small topic of multiple sclerosis.